Today we are going to discuss about the role of simulation and ergonomics in laparoscopic urology. So for anybody who's starting to learn laparoscopic urology, the most important thing is how does he start doing it and how does his transition from open to laparoscopy becomes a smooth affair. So this is what I'm going to discuss. I have nothing to disclose but a few acknowledgements to my teachers that whatever endeavors that I have been able to accomplish are courtesy all my teachers. The learning objectives for this particular talk is that why do we actually need to learn laparoscopy? Then what are the obstacles when you start to learn laparoscopy? How do you overcome them? How do you understand the role of ergonomics in laparoscopy? And what are the simulation modalities that can help you become a better laparoscopic surgeon? And how does learning curve impact a surgeon? So getting started. So it was a very interesting dog experiment by Kelling et al., which actually started the whole issue of laparoscopic urology. They wanted to study the effect of pneumoperitoneum on portal venous pressure so that they could treat the patients with portal hypertension. So this was the genesis of the laparoscopy. Then it went on when people actually did the first laparoscopy in humans to the first cholecystectomy done by Moe et al. And in laparoscopic urology, the seminal step was by Dr. Ralph Kleiman. Recently, we've all had an opportunity to listen to Dr. Ralph Kleiman in semi-live as well as in one of his lectures, where he went on to tell us the story of how he developed the first laparoscopic procedure. It took him 5 porcine experiments to do the first laparoscopic nephrectomy. And only to the bagging component and morcellation component of nephrectomy was the last porcine procedure dedicated. This was the kind of commitment Dr. Kleiman showed to do the first laparoscopic procedure. I always wonder, and I ask to my generation, are we willing to put in that kind of effort to learn laparoscopy? While laparoscopy is growing slowly, it has a steep learning curve because what you see is a 2-dimensional view of a 3-dimensional structure. You don't get any haptics. And there is always an argument that it is a difficult thing to achieve. But if you ask me, why do you want to do laparoscopy? If a single question is asked, why do you want to do laparoscopy? The categorical answer to this question will be magnificent visualization that you achieve in laparoscopic milieu. The recovery is dramatic. Post of pain substantially less. Smaller wounds heal well, and video imaging allows a better learning. So you must do laparoscopy. So how do you start? You are the surgeon, develop this program, develop a team, observe, assist, do. Start with an upper trap extraoperative surgery with a beginner-friendly case like obstruction leading to non-functioning kidney due to a PUG obstruction in a perimenopausal lady. This is very important that you choose a perimenopausal lady because the fat is friendly. The procedure becomes easier. Convince yourself the whole thing is doable. Think, believe, dream and dare, and I'm sure you will be there. This is our laparoscopy team at Muljibai Patel Urological Hospital. The scrub techs are constant, anesthetists are constant. Therefore, the program develops very fast. So as I said, choose a patient with an upper tract abnormality. BMI should be around 25 to 30. Less BMI is not good. Like in open surgery, you don't want a patient with a BMI of 15 to 17, 19. This is not a good BMI. A BMI of 25 to 27 is good. Again, morbidly obese patients are not very good. Extensive prior abdominal adhesions, pelvic fibrosis, organomegaly are not good situations. Ascites, hernia, vascular anomalies are also not good situations. So avoid patients with these and then start your first case. The components of operating room will include imaging systems, insufflators, hemostatic generators, and instrumentation. So why are we discussing them in a class of ergonomics? Because they have to be arranged in a particular way to give the maximum ergonomical output. So if you look at this particular figure, at the head end should be the anesthesiologist's trolley, and then you have a vision card. The vision card has the vision monitor at the top, followed by the camera and the light source, then suction, irrigation, and insufflation device, followed by the ESUs of the electrosurgical units. So this should be the order of placement, and we'll come to know why as we go along. Two screens opposite to each other are always welcome. And if you look at the real-time scenario, if you're doing a left-sided upper tract surgery, then the camera driver stands cranial to the operating surgeon, and the chief scrub technician stands caudal to the operating surgeon. The circulating staff nurse stands behind the operating surgeon, and the anesthesiologist at the top end. So this must be the constant arrangement. This arrangement only changes when you are doing a right-sided surgery and the dissection or the procedure is going on at the level of upper hole of the kidney. Here the relation of the camera driver and the surgeon will change. That means the surgeon will go cranial and the camera driver will come caudal. Before you start to do any operative procedure, there is a checklist, like a WHO checklist. Check whether these things are working well, whether the electrosurgical unit is working well, the suction irrigation is working well, CO2 tank is full, camera is wide balanced, and insufflation is going well, and the Very's needle is checked for the flow and tip retractions. These are very important checklists that you must ensure in the proper condition before you start to embark on a procedure. What are the general principles of an operating room setup? The surgeon and the monitor should be in the same line. The surgeon should be optically correct. Insufflator should be just below the vision monitor. Light source should be on the same cart. All the lines should be free of any tangle. And drapes, pockets should ensure that the instruments can be placed in them. Ideally, two monitors opposite to each other. So this is what exactly you should not be doing, or an arrangement that should not be there in your operating room. The surgeon is trying to insufflate and he's looking behind to look at the pneumocephalic pressures, which is absolutely incorrect. Ideally, the gaze of the surgeon should be straight and he should be looking at the monitor or the thermoflator monitor in a straight gaze. This is a custom-made drape where you can put in all the instruments and the lines are tangle-free so that you get the maximum movement out of each instrument. These small things will smoothen out your procedure and decrease the frustration barrier as you go along the procedure. These are cloth-made sewn drapes which can also be used, or pockets which can be attached to your routine drapes. Now, how does a camera driver stand in relation to the operating surgeon? The camera driver should give enough freedom of movement to the operating surgeon. If the camera driver is tall, he can sit down as compared to the operating surgeon. Now, coming to the main bit of it, what are the most important pillars of laparoscopic surgery? Ergonomics, task analysis, and psychoengineering. Out of which psychoengineering means nothing but knowing a little bit of your gadget. Means how do the lines go, if CO2 is not coming, is the tube actually kinking rather than anything else. So small bits to know your machine a little is psychoengineering. Starting with ergonomics. So ergon means work and nomos means laws of nature. So fitting a man to the environment or creating a good environment for a man to work is basically ergonomics. Ergonomics necessarily is of two types, sensorial and physical. So sensorial ergonomics is what provides you better vision. Physical ergonomics gives you physical comfort like appropriate temperature, relaxation to the body muscles. So this is what physical ergonomics is eventually going to give you. But why so much of humbug about the laparoscopic surgery? Because the vision that you get is two-dimensional. There is loss of depth perception. In a laparoscopic milieu, there are only 4 movements that are possible. You can go in, out, you can move left, right, you can move up, down, and you can do a rotational movement. So these are the only 4 movements that are possible in any laparoscopic milieu. As opposed to this, when you are doing an open surgery, the degree of freedom is 6. And if you are doing a robotic surgery, the freedom movement is 7. That means your hand can actually flip on itself. Second important issue with laparoscopic urology or laparoscopy in general is that all instruments behave like a lever. Means they move around the fulcrum. So if you move your handle down, the tip inside the abdominal cavity moves up, and if you move your handle right, the tip moves left. So this counterintuitive sense and a lever phenomenon of each instrument make the procedure difficult. Another important thing that you must remember is that in all laparoscopic procedures, there are 4 movements, out of which 2 are actually counterintuitive and 2 are intuitive. The rotational movement is intuitive. The rotational movement and in and out movement is intuitive as compared to the other movements which are counterintuitive. What makes laparoscopy surgery actually very difficult is there is a decoupling of visuomotor axis. Orientation changes, something that you were used to seeing outside in, now you are visualizing inside out. Imagine seeing a ureter or a gonadal vein. In the open surgery, you first see the psoas muscle and then go to it. In an open surgery, you first actually see the gonadal and ureter and then see the psoas. This is also to do with the approach, but in laparoscopy in general, you'll visualize the structure from within, and in open surgery, you'll visualize the structure from outside. You keep standing for a long duration. This leads to pain, fatigue, and decreased efficiency. So these are the issues with laparoscopic surgery. Now, when you are considering any laparoscopic surgery, what is the most important thing that will give you comfort or which will allow you for working over a period of long duration is ergonomic comfort. So ergonomic comfort, when you talk about ergonomic comfort, the most important thing is level of your instrument. The level of your instrument should always be at the level of your waist. So this will keep your shoulders at rest. Your elbows will always be in a neutral position. The angle that your 2 working instruments make is the manipulation angle. This manipulation angle should be around 60 degrees always. Remember all the critical things that you have been doing in life, like painting, eating with a knife and fork, for that matter, suturing in an open surgery. The angle that the instruments in both your hands form is the manipulation angle, which is actually 60 degrees. Coming to the azimuth angle is the angle that an instrument forms with the laparoscope. This angle should be around 30 degrees, never less than 15 and never more than 45. One thing is, whenever you keep laparoscope between the 2 working instruments, the depth perception is far better than keeping it on one of the sides. And this angle helps you gain a better depth perception. Elevation angle is an angle that your instrument forms with the body of the patient. This angle should never be more than 60 degrees. Once it goes more than 60 degrees, then what happens is your shoulders start to get abducted, and over a period of time, you will start to have a lot of pain. There are several electromyographical studies and pain studies done on surgeons that when these 3 angles, that is the manipulation angle, the azimuth angle, and the elevation angle have been within the normal limits, that the pain and the fatigue to the surgeon has been less. As opposed to this, whenever they have been more, the surgeon gets tired, fatigued, and this has also been demonstrated by electromyographic studies, not only by pain scores. So this is the elevation angle that you should not be having. When you have a large elevation angle, your shoulders get abducted a lot, and there is a lot of strain on the neck muscles. Now coming to the lever principle, it is very, very, very important to understand the lever principle. All the instruments in laparoscopy work on the lever principle. That means that instruments move around the fulcrum. So if you look at the figure 1, this is the fulcrum and this is the instrument. The part which is outside is the lowered arm, and the part which is inside the abdomen is the effector arm. So whenever half of the instrument is inside and half of the instrument is outside, the translation of movement will be 1:1. That means if you move your instrument 1 centimeter to the right, the tip will move 1 centimeter to the left. In other words, the movement of the lowered arm and the effective arm are equal. Imagine a situation where 3/4 of your instrument is inside and only 1/4 of your instrument is outside. In this situation, what will happen is the movement inside will increase. That for every unit movement done outside, the tip of the movement will move much more. That means the force will get rectified and the movement will get magnified. Imagine a situation when you are doing a dissection of the upper pole of the left kidney. 3/4 of your right arm instrument is inside, and you are trying to push the right upper pole away from the spleen. The movements are enhanced, and when you apply a small force, the tip of your instrument may just wobble and hit the diaphragm. So this is what you must avoid by placing your ports properly. One more situation that can arise is that your instrument is too much outside. That means 3/4 of your instrument is outside and only 1/4 is inside. This will lead to an enhanced elevation angle, as you can see in this video. One more major problem that occurs in this situation is that if you are using a metallic port, the current from tip of your instrument may go and hit the port, and capacitive coupling may occur, injuring the bowel. This will typically occur if you have placed the port too close to your target organ. So placing port in a way which makes half of your instrument inside and half of your instrument outside will give the best result. In ergonomics, one more important cue that you must always learn is a depth cue. So there are several depth cues. Why an experienced surgeon laparoscopically is able to achieve a task very quickly as compared to a novice? Because an experienced surgeon over a period of time learns to adapt to the depth cues. So what are the depth cues? Keep looking at this video, which is running in a loop again. If you look at this needle, the needle is in the front of the chicken bone. That means it will cast a shadow on the chicken breast. So the moment it casts a shadow on the chicken breast, you know that it is occluding a portion of chicken breast. That means it is nearer to you than the chicken breast. Look at the relative size. As the lens will go towards the needle, the size of the needle will appear to increase. This is the principle of relative size. Look at the aerial gradient. The edges of the needle become sharp as the lens goes towards the needle. Motion parallax is nothing but the enhancement of movements of the needle as the laparoscope approaches the needle. So imagine a situation where you're trying to dissect the renal hilum, and when you take your lens really close to the renal hilum, the pulsations of renal artery will get enhanced. So what is linear parallax? Linear parallax is something, two parallel things appear to meet, but when you go closely, you see that they never meet or they meet at infinity. This is linear parallax. Texture gradient is something that, look at the chicken breast. The furs on the chicken breast appear sharper as the camera goes closer. This is texture gradient. So understanding that something which is superficial or nearer appears bigger, moves more, appears brighter. Anything that is farther appears dark, appears smaller, and appears to move less. This is an importance of depth cue in actual laparoscopic surgery. So why worry about depth cues? Just have a look at this video.
फर्ज करो, लड़ाई के दौरान अगर तुम्हारी आंखों की रोशनी चली जाए, तो तुम अपने सामने खड़े हुए दुश्मन को उसके कदमों की आहट से और उसके वार को हवा के रुख की काट से पहचान सकते हो।
So what this video tells us that one of our senses, once not working, some other sense may help us. Like in this particular scenario, he developed his hearing sense to forego the disadvantages that were caused by loss of vision. Similarly, in laparoscopy, whenever we have loss of three-dimensional vision, The depth cues will help us understand the importance, or they will get aligned with a two-dimensional vision to give us the details of three-dimensional vision. That is what depth cues do for you. Now, to achieve all the ergonomic considerations that we were talking about, most important thing is placing the ports ergonomically. So the basic concept that we use to place ports is a baseball diamond concept, where you have a target organ in center, of a telescope exactly in the line, and two working ports on the opposite side. How do you achieve this? So you draw this diamond with your hand, and you place the tip of your fingers at the level of the target organs. The summit of your thumbs will give you the position of the telescope, and your anatomical snuff box will give you the position of the working ports. But the question is, how do you come to this conclusion? So you measure the tip of your thumb to the anatomical snuff box. The distance may be anywhere between 7 to 9 centimeters. Now you look at all the different laparoscopic instruments. So this instrument, this middle instrument, is a typical adult instrument, which is about 36 centimeters in length. So if you were to obey the lever principle, 18 centimeters of this instrument would be inside and 18 centimeters would be outside. And if you were to extrapolate the same thing to a pediatric instrument, which is about 28 centimeters, so 14 centimeters will be inside and 14 centimeters will be outside. Okay, what the triangle law says that if you want this angle to be 60 degrees, all the three angles should be 60 degrees, because it will be an equilateral triangle. So imagine a situation where you have 18 centimeters here, 18 centimeters here, and 18 centimeters here. Now the telescope should be exactly in the middle, so that your azimuth angle is around 30 to 45 degrees. So to achieve that, you place it at 9 centimeters. So both lateral ports from the camera ports should be 9 centimeters, which is nothing but your 4-finger rule, or measuring your tip of your thumb to your anatomical snuff box. By this configuration, you can achieve a manipulation angle of 60 degrees, azimuth angle of 30 to 45 degrees, and elevation angle will be always less than 60 degrees. Choosing your ports carefully is an important ergonomic consideration. If your port is very large and the instrument is too small, your instrument will wobble inside the port. This is called as gesture imprecision. Imagine a situation where you're doing fine suturing, and you have a 10 mm port and a 5 mm instrument is working through it. Your instrument will keep wobbling inside the port, which will decrease your precision. So gesture imprecision is an important consideration for ergonomics. Mirror imaging is an important thing. Your assistant is retracting the ureterogonadal packet standing opposite to you, and he's seeing everything that you see in a mirror image. So don't expect him to be as facile as you. Put in an instrument in the retracted position and then only hand it over to the new assistant. So this is an ergonomic position that I was talking about. Head is straight, in line with the trunk without rotation, shoulders relaxed, arms by the side of the body, elbows bent to 70 to 90 degrees, forearms horizontal, pronated and relaxed, waistline at the level of the table, gaze is down, straight line principle is followed. So to achieve this, your operating room table should be at your level, at the level of your waist. That is an important thing. The monitor should be in straight line. So the surgeon, pathology, and monitor should be in straight line, and the monitor should be about 15 degrees downwards, so that there is no stretch in sternocleidomastoid and ocular muscles. So this is what you are looking to achieve, a down 10 to 15 degrees downward gaze. The distance at which you stand from the monitor should be 5 times the diagonal length of the monitor. So for a 21 inches monitor, you stand at about a distance of 105 inches. At this distance, formation occurs perfectly at macula and the acuity of vision is best. OT should be well illuminated, needless to say. Now coming to the second important component, that is task analysis. Whenever you do something, drop it into or divide it into small components, procedural steps, executional steps. Like you talk about procedural steps of putting ports, but how do you execute it? That is the most important thing. Put in a varies. That is again a procedural step, but how do you put in a varies? So you make an incision which is about 2 to 3 millimeters, hold the varies like a dart, push it through the abdominal wall, you will hear 2 clicks. When you hear the second click, attach a syringe to the hub of your varies needle, aspirate for air, blood, bile. If you get air, that means you are in a free space. Then do a hanging drops test. So these are the small executional steps that help you achieve a varies needle insertion. So whenever you are thinking about a single step, divided it into small 10 steps and then try to execute it. Training in laparoscopy is very important. You understand what are the ingredients of a typical laparoscopic surgery. Then understand the learning curve. How will simulation help you and how mentor will make a difference is the important thing to understand. So if you look at the theory of, which was theory of achieving motor skills by Fitz and Posner, what they proposed is that initially you try to do something while putting in lot of effort. Then comes a stage where things come to you a little naturally, and then there is a stage where you do things at spinal level. This is the stage that you wish to achieve in dry and wet lab, and then transfer the skills into the real-time situation. Okay, so now I start my section on simulation in urological practice. The simulation is important because that will take, the simulation will take you from a stage of a novice to a pre-trained novice. Pre-trained novice is a person who has all the cognitive skills, all the motor skills that are required to perform a procedure. And then when actually he goes into the operating room, he just has to concentrate on the anatomical variation, complications, so on and so forth. So we started this debate about 2 years back in Indian Journal of Urology. What are the pros and cons of simulation-based training? So to begin with, I will tell you what are the few simulations that you could potentially use in your own settings. So this is a classical homemade endo trainer or box trainer. So this is a box trainer made of steel. It is open at the base, has multiple holes above and on the lateral surfaces, and the surface which faces you has a hole for camera. So you can put any exercise that you desire into this setting and use your own laparoscopic system to execute a particular exercise. Agreed, you don't have it. You don't have a laparoscopic set at all. How would you go ahead and do this? So this is what you can use. This is a self-designed endo trainer, a wooden board with multiple holes on both the sides, and your smartphone can be used as a camera. It is elevated to 9 inches at the rear end and 5 inches at the front end. Rubber cocks out of the contrast bottles are put as the ports. This horizontal bar is meant for holding the mobile. So you visualize any task that you want to do. This is how you can accomplish any task, dry lab training task in your own backyard. This office endo trainer will help you enable all the training tasks that you could do with a commercially available endo trainer. You may find it bulky. This was the design that we had tried to make about 3 years back. But we have a new design. We have a new design, courtesy Dr. Abhijit Patil, who's a fellow in our department. So he has devised this particular model, which uses two phone holders actually, nothing but phone holders. These phone holders get conglomerated, and then you can place your mobile in the center. These acrylic shafts have the ports in them, so you can put in your instruments and then practice the desired exercise. One more advantage of this particular feature is you can do some telementoring. So you can see a trainee is trying to follow his mentor by using the picture-in-picture model of the mobile. So there are various uses of technology that can be brought in to training in laparoscopic urology. Here you see that the trainee is trying to do laparoscopic suturing exercise, watching his mentor. So telementoring is a thing that is possible using the smartphone devices. This is the commercially available endo trainer. We all know it is a costly affair, about 10 to 12,000, requires a separate television, But if your institute can afford it, then it is also a very, very effective tool to have. Now I will talk about various models that can help you practice various exercises. We all know that bead models, glove transfers, and various exercises that can be done in dry lab. Now, one dry lab exercise that simulates a surgery is a glove pyeloplasty model. So what you do is inflate a glove. So the thumb and the base of the thumb is cut like this. And then a Foley's catheter is introduced from the tip of the thumb, which is tip of the thumb is cut, and that Foley's catheter is introduced, and the Foley's balloon is inflated. So this is how it looks. It looks like a pelvic-ureteric junction obstruction. This is a dilated pelvis. Here is the catheter. And the plan is to cut it right here and then sew it back. If you compare it with the real time, this is the pelvis of the kidney, ureter, this is the PUJ. So you make a cut here and then sew it back. The final appearance is something like this. This will help you practice suturing and practice the pyeloplasty operation in a dry lab. Now we'll quickly shift gears and move to wet lab situations. What simulation models can you use in wet lab to achieve training in a particular surgery? So this is a box simulator that we developed. My colleague, Dr. Jaspreet, and my mentor, Dr. Kanpule, they had developed this particular box simulator. And what this necessarily has is that it has a place for cannulation of aorta. You can place the simulation model here, and then here it has, the box has been kept upside down, and then there are ports which are placed at the superior surface, and this hole is for the camera. So you place the model like this into the box that I just showed. So this is a porcine cadaveric model. Here is the kidney. Here is the aorta, which is cannulated. So what you do is you connect the cannulated aorta to a pump. It can be a Euro pump, which you use in the ureteroscopies, a device like that, and you push in colored water here. So add some color to the water, and the water will keep going here. So eventually, if you end up cutting vessels during your dissection, there will be bleeding. Or you can deliberately cut a vessel and then try to achieve control of that vessel. So these are different simulations that you can practice. A conventional nephrectomy can always be practiced in this particular situation. Also, what you could practice is a partial nephrectomy. So in the same model, you could just score an area of kidney, mimicking a tumor, and then resect this portion of the kidney and then sew it up. So this will help you practice a partial nephrectomy. Of course, you have to take a higher control because the blood which is coming from aortic cannulation will keep leaking from here. So that will also be a very, very good training exercise, I would say. So some other training models that we have developed based on chicken anatomy. So our interest in actually working with chicken anatomy started when Dr. Ramchandra and Dr. Kurian started their work on pyroplasties. This was taken over by Dr. Arvind Ganpule sir, and then by me, and followed by fellows at MPUH. So what important anatomy that we need to know in the chicken is that in the neck there is a trachea, esophagus. The stomach of the chicken comprises of three parts. The crop is the first part, then the proventriculus and the gizzard. These five structures will help us do many variations in simulation. So first you look at the chicken pyeloplasty model. So chicken pyeloplasty model, this is the neck of the chicken. The chicken is furred, beheaded, defurred, and kept on its back. So esophagus mimics the ureter and the crop mimics the chicken. So you incise the skin in the neck, dissect out the esophagus circumferentially, clip the esophagus, spatulate the esophagus laterally. Then you make an incision onto the crop and start suturing like you would do in pyeloplasty. Take the conventional angle stitch first, followed by the posterior layer and the anterior layer. So this will be a very good simulation for you to learn pyeloplasty. You could also learn a ureteric reimplantation. This is what we presented and published subsequently in the Indian Journal of Urology. So you orient the same model with the head towards the operating surgeon and the body away. Then this time you dissect the ureter which will be the trachea, and then you take an incision over the crop, dissect the skin all around, and the blue hue will represent the bladder. Then you do the suturing and then close the crop skin like you would do the detrusor myography. So this model will quite closely resemble a ureteric reimplantation model. Here the esophagus will mimic the common iliac arteries and the crop will mimic the bladder. Once you make the incision, the incision would be like a detrusor incision, and the bluish hue of the crop will represent the mucosa of the bladder. The hitch stitch that you have taken helps the crop hang and not empty when you are doing the procedure. The third model that we are going to talk about is a uretrovesical anastomosis. So this has been adapted by a model which was described by Laguna et al. So what basically we do is that orient a chicken, but after you open the breastbone of the chicken and eviscerate the chicken, you look at the proventriculus and the gizzard. So this is the eviscerated chicken, this is the proventriculus and the gizzard. Then you take an incision at the level of proventriculus and the gizzard, dismember them completely. This will appear like a bladder and urethra after radical prostatectomy. Then you start suturing with the bidirectional needle. Start at 6 o'clock in the midline. First enter the gizzard and then sequentially keep on taking sutures bidirectionally to complete the posterior plate, pass a catheter, and then complete the anterior plate. Another important model that we have been working on is the chicken neobladder model. So here what you use is basically the trachea, esophagus of the chicken. You defer the chicken, behead it and place it on its back, open the breastbone, eviscerate the chicken and keep the proventriculus intact and eviscerate everything else. So it is like working in the human pelvis. These are the lateral pelvic walls which mimic the actual human lateral pelvic walls. So you anchor the esophagus on one side and the trachea on the other. So these mimic both the ureters. The proventriculus cut end will mimic the urethra, and you take about 70 centimeters of bowel. This bowel can be configured at 22 and 22 centimeters, leaving rest as the chimney. Now you open this particular model. So you can place this particular assembly into the box trainer. You first do a urethral anastomosis with the bowel, so ureteroenteric anastomosis. Once the ureteroenteric anastomosis is done, then you open the bowel along the antemesenteric border, form the posterior plate, and then cross-fold like the Karolinska group would do, cross-fold the bladder. After this, you close all the remaining openings and attach both the ureters to the chimney. This is the final figure that you will achieve. You can test it by putting some saline. Once the ureteroenteric anastomosis is getting completed, you can pass in a catheter through the esophagus, which will come out here, and then place the catheter into the neobladder. So these are the different simulation models that you can make in your own backyard and keep practicing them to achieve proficiency in laparoscopy. One may argue that difficult laparoscopic models like neobladder may not have a place in routine practice. But remember, when you practice 10, you will be able to perform 7. So more difficult practices that you do, they'll make you better surgeons, or they'll improve your motor skills to manage different kind of situations. Now, if you were to start to do a laparoscopic surgery, you must know the ingredients of a surgery. The anatomical knowledge is the most important thing. That is always aided with radiological information. And understand your laparoscopic anatomy. Laparoscopic anatomy, in essence, is not same as open surgical or surgical anatomy. Because your approach is different, the anatomy that you see is definitely going to differ. So if you want to see the gonadal vein, you have to first reflect the colon from the Girota's fascia. Then only you can see the retroperitoneal structures. This is opposed to a retroperitoneal open approach. Whenever you decide to do a particular procedure, divide it into procedural steps, which all the textbooks will tell you. But the most important thing is divide each procedural steps into tiny executional steps. The smaller the executional steps, the better will be your ability to achieve them. Arrange these all steps in a sequential manner and get started. So let's see an example. Here we are trying to demonstrate how do you lift a ureterogonadal packet. So identify the ureterogonadal packet. That is done by first reflecting the bowel. Now duodenum is cauterized, bowel is reflected. Now you see a white structure which is running cranio to caudal direction, has some fine meshwork of capillaries around it, and has a thin, white, but tough fascia in front of it. So the second thing to do is, after identification, is to incise the anterior gyrotous fascia. So once you incise the anterior gyrotous fascia, you will see psoas muscle, and keep lifting everything with a blunt force. Where do you start doing this? At a point where the gonadal vein is crossing the ureter, and how caudally you will do it till the iliac crossing. So these are the many small steps that you need to follow or execute in achieving one step of lifting the ureterogonadal packet. When you are doing this, is the learning curve very long? Yes, the learning curve is there, but it is not 10,000 hours. As Malcolm Gladwell said, that to master any skill, you require 10,000 hours. You can start gaining some kind of proficiency once you reach 20 hours. Deconstruct the skill, learn enough to self-correct, remove distraction barriers, remove all the frustration barriers. Let's see a video clip of a novice when he is starting to do a surgery. So you see the tension with the left hand is really poor. He should have pulled the structure more tautly so that the structures would open and the gas would enter the retroperitoneum. The movements are a little tentative. Also, the movements are not in a continuum. So if this novice surgeon goes back to his video and sees these particular things, the next time he does it, he'll be able to self-correct. So there is an immense role of reviewing what you do. See, the left hand in this particular situation was just not moving. So if I were this novice surgeon, I would tell myself that I did not use my left hand adequately. So I should practice exercises with my left hand. The traction and counter traction was inadequate. So I should lay emphasis on that. My movements were unplanned. That means the basic executional steps of surgery were not printed in my mind. So this will be my take home message from this particular video. And that is what I advise everybody. Another important thing is, are we thinking about training in the way that people in professional sports or music are? So these are the two gentlemen I met at gym. They used to practice a particular exercise. Like this particular thing I used to practice is latissimus dorsi pull down every day. I asked him, why do you do this exercise every day? He said, I am a bowler in a T20 league. I need a lot of wind under my wing to throw the ball hard. I was wondering to myself, I am a surgeon in a more intense profession than he is. What am I doing to train my shoulders, my wrists, and my forearms? That day I decided that I would do some exercises to keep my shoulders and forearms in place. Practice isn't something that you will do once you are good, but it is something that will actually make you good. 10,000 hours is what Malcolm Gladwell gave us. This rule comes out of his book called The Outliers. That is 8 hours a day, 5 days a week, 44 weeks a year, and 5.5 years it takes. So I would advise you, better get started now. When you do this for 5-6 years, what is the effect of it? He's a world-renowned, these are the hands of a world-renowned vascular surgeon, Dr. Arun Fairwani. And this is what you see after 10,000 hours. Here we see the hypertrophy of first dorsal interosseum. The effect of the input of 10,000 hours is so subtle that an uninitiated person may not be able to even recognize it. But it is definitely there for the ones who want to see it. I leave you with this last thought. Top athletes and singers have coaches. Why? in surgery, especially in laparoscopic surgery, are we afraid to have coaches? Why are we afraid to have simulation models when we know that convincingly they can make us better surgeon? So at present, even if you are here, I'm sure in a time to come, you will become mythical. Thank you for a patient listening. Stay safe, stay healthy. If there are
Thank
any
you.
questions, I will be happy to take them.
Yeah, first of all, thank you, Dr. Abhishek sir, for an exhaustive session. And it was a really, really interesting session with a lot of good videos. Plus, for understanding of everyone, I think you've described very simply, in a very simplified manner regarding all the simulations that are available. So we have, I think, only one question as of now. So the question is, any place where and how to prepare these models and where they are available? This is from Dr. Madhav Tiwari.
Okay, so Dr. Madhav, what you could basically do is you can prepare them yourself. I do it myself. So you get a deferred and beheaded chicken like you would get from a butcher, and then put in an infant feeding tube into the esophagus. Just wash it 1 or 2 times, and once you wash it, the crop will get distended, and you press the crop. So all the food particles will come out. So once the food particles come out and your saline or the water that you put inside is clear, you can put in an infant feeding tube into the esophagus and do the procedure. As simple as that.
We have another question from Dr. Vinay Kumar Shukla. He wants us to explain about mirror imaging.
Yeah. So, Dr. Shukla,
Vinay.
what happens is that if I am an operating surgeon and if somebody is standing right in front of me, the things that I am seeing through laparoscopy, the exact mirror of it is seen by a person who's standing in front of me and looking at a screen behind me. So if I see a structure at right, the same structure will be seen at the left for my assistant standing opposite to me. If I want the assistant to move the instrument right, then he actually moves it left. So this is the kind of jugglery that happens with the assistant. Okay, Dr. Mittal wants me to answer that. How can I he wants me to explain the triangle method. Okay, so I just stop my sharing screen so that I can go to a complete video of mine. And
sir, there are a lot of questions which has been raised. A lot of participants have raised the questions. My request, if you can just put the questions in the chat, and Dr. Abhishek sir will be able to answer it.
yeah, so Dr. Okay, Dr. Shukla, Dr. Mittal wants me to answer that what is the triangle method. So watch my hand then. So this is basically a triangle. It's an if you look at the isosceles triangle, sorry, if you look at an equilateral triangle, all the three angles are 60 degrees. Now, by lever principle, you want half of the instrument, half of all your instruments to be inside, half of the instrument to be inside, so that the translation of movement at the tip is 1:1. So you should form a triangle. An equilateral triangle will have all three sides equal. So if you're looking at 18 centimeters of your instrument inside, all three sides of the triangle should be 18 centimeters. Now look at the base of the triangle. Base of the triangle is 18 centimeters, and you want the camera to be in the center of this. So 9 centimeters on each side. So this is how you can place. So apex of your triangle is your target organ. The two corners of the triangle are basically your working instruments, and in the middle you will have camera. So this is how you will get a proper triangle configuration. Dr. Madhav again has a question. What suture should he use? The second bite always seems to be slightly more proximal to the first bite. Any way to keep both bites exactly parallel? Okay, I can give you some tips on suturing. Keep your ports a little closer to one another. Like if you in a nephrectomy would keep it 9 centimeters, here you keep it 7 centimeters. Use a needle size which is about 40, needle which is about 40, and then you follow the principle of traction and counter traction. That will help you achieve parallel bites. Always imagine your needle like a clock. So the most common direction in which you'll throw your needle is from 3 o'clock to 9 o'clock. But when you're practicing in a dry lab, practice all the angles like 3 o'clock to 9 o'clock, 9 o'clock to 3 o'clock, 2 o'clock to 5 o'clock, 2 o'clock to 7 o'clock, 7 o'clock to 11 o'clock. When you keep practicing these angles, no angle is going to be eventually difficult for you. Dr. Deepu Singh wants me to answer intuitive and counterintuitive movement. So Dr. Deepu, just have a look at my screen. When I am intending to move this instrument or this pencil inside, and I'm moving inside, this is an intuitive movement. Now I want to rotate this particular pencil clockwise. So I'm actually moving it clockwise. This is an intuitive movement. But now watch this movement. Now I want the instrument tip to go down, but my hand is going up. So this is a counterintuitive. So laparoscopy is made out of two intuitive and two counterintuitive movements. When you start to do laparoscopy, counterintuitive movements are more than the intuitive movements. That is what makes it difficult. So Dr. Venugopal wants me to ask what is my experience with V-lock sutures. It is very good, but I would never use it for pyeloplasty, though people use it for pyeloplasty. How to take care of fogging of camera? You can put in some betadine-like solution, or more so, keep a thermos with hot water onto your lap trolley. Keep submerging your instrument into the hot water, followed by a nice wipe. That will do the trick. When do you prefer the hook? Any difference in conduction if you use back of the hook or tip of the hook? Dr. Venki wants me to answer this question. I prefer to use the hook when I'm dealing with the tough structures and I want the things to be more precise. Like when I am opening the anterior girotas, or when I am opening the fascia anterior to the renal vein. As a matter of principle, I never use the back of the hook, because hook, as the name suggests, is meant to hook, and not the back of the shoulder should not be used, because unless you have a great control, you may end up causing injury. So a port position for the pelvic surgeries, again, you make the diamond, and your target organ should be at the tip of your index fingers. So place both your index fingers of the diamond at the level of pubic symphysis, and rest will be shown by your anatomical snub boxes and the summit of your thumb. Okay, so now there are people raising their hands. Do we take them, or what do we do?
Sir, if the time permits with you, because there are some chats also, there are some questions in the Q&A as well, sir. So if you think
so
that
I'll answer the questions in Q&A. I'll try to answer the questions in Q&A, and I'll end sharp at 1, because we have another program coming.
Okay, sir, no problem.
Which is the best institute to learn laparoscopic urology. With all humbly and modesty, I would say Mujibhai Patel Urological Hospital. Venki's question I answered. Raj, in laparoscopy, one needs to work with both hands. What is your advice for a novice to overcome the hand dominance? So Raj, what I would suggest is keep practicing things only with your left hand. Like if you're doing simple exercises like bead transfer in a dry lab, do it with the left hand. Do suturing exercise completely with the left hand, making right hand as your assistant. If you keep doing this over and over, you'll be better. Which instrument should be purchased to start initial practice? Which brand, if any? Dr. Ashish, my good friend. So Dr. Ashish, what I would suggest is that if you have to do a one-time investment, buy everything which is from Storz or Wolf. They'll last you for life. And I personally like all the Storz instruments. Indian instruments by RK are also good. And if a budget is a constraint, you can go ahead with that. Should hemlock be avoided in lab donors? I would say there is plenty of evidence to suggest that hemlocks can be used in lab donor. If you look at the meta-analysis by Liponsky, he says that whenever the seminal rules of clip application were followed, that is dissection of a tubular structure circumferentially, seeing the knob beyond the structure, clipping to hear a click, and 2 clips on the donor side, leaving a cuff of 2 millimeters. Whenever these seminal rules are followed, there'll never be a catastrophe. What is the threshold for opening in the initial period? I would suggest, rather than keeping a threshold, when you start to do, start in such a way that today I'll only do bowel reflection and then I'll convert. The second time you say, okay, I'll lift the ureterogonadal packet and then convert. That is the time. That is the way you can go. And the threshold should be, even if you are not able to progress for a period of 15 minutes or 20 minutes, then you better convert rather than heading for a complication. There should be no ego involved in conversion, because everybody is a very good open surgeon. Okay, so I answered all the questions. If you want, I can take one of the hand raises, 1 or 2 of the hand raises, and then finish the whole session. Should I?
Yeah, sir. The only thing is, those who have raised hands, please drop your question in the chat, because that is the most convenient way, and sir can take one question or 1 or 2 questions from it.
Okay, Amit Verma wants to ask me, can we start lab with monopolar and bipolar only? If you have a bipolar energy, yes, you can definitely start. The irony is that when you get trained in laparoscopy, you could do all the procedures with monopolar and bipolar. And during the starting course of your training only, you require advanced energies more. So if it's a simple nephrectomy, you could do that. But more vascular ones would be difficult to do with only mono and bipolar. Okay, then Manan, I think I answered everything. Over to you. There are okay, there are hand raises, but since it's a webinar, we can't unmute them, right?
Yeah, sir. Yes, sir. So I think on behalf of Dr. Reddy's team, sir, we'd like
okay,
to.
I'm sorry. I'll just answer this question. Hi Yogesh, I'll answer your question. At what level of skills should one start doing lab donor? I mean, few initial steps at least. So I would like to quote Dr. Mahesh Desai here. He always said that unless you have completed 20 complete laparoscopic procedures, don't think about lab donors. So 20 is where you get initiated. Okay, I'm sorry. Mr. Mrinal, please go ahead.
Yeah, sir. So I think we had an excellent deliberation of today's session, more specifically about the training part. And thank you so much, Dr. Abhishek, sir, for giving us the clarity and for your information. I think we have been witnessed with almost 150 plus participants in today's webinar, which is excellent. And the feedback of all the doctors who have attended, they have given a very, they have acknowledged you, sir, with excellent presentation and excellent clarity. And thank you so much for giving us your valuable time to Dr. Reddy's. And I request my marketing team to speak or conclude this session.
So thank you, sir. And it was really interesting. The videos played very nice. And that was, I think, the most important thing, because being a surgeon, it is always interesting to see something which is going, very nice and smooth. So thank you very much, sir, for your time. And I would request, thank you all, the participants to coming and attending the webinar. Just one request: when you leave the webinar, click on end meeting rather than just, closing the window. This is for the, security purposes as well. So thank you, sir. Thank you very much for your time, sir.
Thank you, man. Thank you, Mr. Murli. And I also see Mr. Padmanabhan logged in. Sir, good afternoon, and thank you very much for the opportunity. And as always, it's a pleasure doing anything with Dr. Reddy's lab. It's my pleasure indeed. Thank you for a patient listening. Thank you.
Thank you, sir. Thank you all, and be safe.
Thank you.